welcome to Spine Conference. Today's discussion, thanks everybody for coming. Today's discussion is going to be, the topic is cervical myelopathy and diffuse idiopathic skeletal hyperostosis. So Allison, can you present the case?
Sure. So this is a 61-year-old man with neck pain. 2 weeks prior, he extended his neck in the boiler room to view a gauge and felt immediate severe neck pain, had some lower back spasms, and an electrical fence sensation in the buttock and posterior thighs. He initially went to his PCP the next day. He got some steroids. He was feeling fine.
He felt absolutely fine after the steroids, so he has no symptoms. Okay, keep going.
And then he had
the last 6 months.
6 months of his legs felt like they were out of control. He couldn't really move them the way he wanted to.
Around the side there, especially up and down steps. Okay, so what is it when you Lermit's from not? Oh, I said it.
Yeah.
So it's electrical sensation with motion of the neck. Lermit's phenomena. And what do you think of the...
more common in flexion or extension?
Actually, I don't know. I always thought it was flexion and axial load. I don't know. I always thought Lermit's was like in this cartoon, you have an anterior lesion, right. You flex it over the spinal cord, and you get an electrical sensation. Lermit's. I don't know.
I mean, I've seen a lot of patients who extend and get it. So I'm just curious.
I mean, it makes sense, yeah. So you extend.
You can have the posterior ligaments kind of bulging.
Exactly, yeah.
The spinal canal.
Yeah, I think this is Lermite. He was a neurologist in France around the turn of the century, and he was a neurologist. And interestingly, at the end of his career, he did studies on demonic possession and something called stigmatization. He was very religious, Lermite. It's a nice picture. But I mean, it doesn't matter. It just it's a neurological.
Or extension, basically.
Yeah, so it's a weird. So what do you think of the X-rays? Ray, why don't you say what you see on the X-rays here?
So on the left, you have a lateral view cervical spine X-ray, 3, 4, 5, 6, going down to C7, T1. He's got a lot of anterior osteophytes at 3, 4, 4, 5, 5, 6, and 6, 7. Almost as if he's autofused at 5, 6, and 6, 7. So he probably has some, spondylitic sort of disease. I mean, like a dish potentially, or some other
massive osteophytes, really big.
Very unusual, yeah.
Yeah, and the discs are normal,
right.
So it's not a degenerative disc disease picture. And then, so I just wanted to. This was sort of important to me that the T1 tilt was 44 degrees, which is a lot. Usually, it's around 20 degrees. So his neck has to do a lot of extension to look forwards, typically. And we're going to talk about that later. I thought the obliques were kind of non-contributory. The frameless look open. And this was his pain diagram, which is kind of interesting. He circled the neck, the thoracic spine, and the thighs. He says, that's where I get my pains. But right now, he said, I feel fine. His thoracic x-rays showed diffuse flowing osteophytes. And the quintessential diagnosis for DISH is 4 levels of flowing osteophytes from T7 to 11. It's a bone-forming lesion. So, Ray, what do you think of the MRI, sagittal cuts?
So on the left side, it's sagittal MRI, T2 weighted, 3, 4, 5, 6, at 6, 7. He's got a large disc herniation with focal narrowing, the spinal canal. There's no CSF there. It's probably like 7 or 8 millimeters, maybe 6 millimeters of AP diameter. And then also at C7, T1, he's got narrowing. He also has a posterior hypertrophy of the ligamentum flavum at C7, T1, and it's embuckling posteriorly on the spinal cord.
Yeah. So it's both anterior and posterior compression, and it was good. And this kind of didn't add too much to the. So, Ray, what do you think of the axials? It goes like across.
Sure. So at the C6-7 disc, he's got a large focal disc herniation. You can see the spinal cord's compressed. It almost looks like a sausage, especially on the left-hand side. There might be, it's hard to say, but there might be like a single pixel of hyperintensity on the T2 weighted image which might be a myelopathy on that left side. And then it looks like if you look at the C7, looks like there's some ossification of the posterior longitudinal ligament. You can tell that by that wide base, sort of like upside down T sort of formation right there. And then at C7T1, he's got a nice size cervical disc herniation. I guess my question to you is, does he have any weakness in his hand? Because he's probably compressing that C8 nerve root.
No symptoms. This guy's a laborer. No symptoms.
Right. No radiculopathy, nothing.
Nothing. Kind of interesting, right?
Yeah, it's unusual because with a disc that size, you'd expect some weakness or numbness in his C8 distribution.
No symptoms. I mean, it's kind of shocking.
Right.
I mean, to me, that means this has been a slow, progressive process.
Right.
We're just adjusting to it.
Right. Exactly.
Because if you see that, usually in the office, it gives symptoms.
Right.
Classic, yeah.
How old is this patient, Stuart?
69. Hold on. No. He's 60. He's not that old. 61. Yeah, he's still working. Active guy, nice guy too, actually. So, can you explain a couple of these?
Yeah, so these are the signs that you might see on your physical exam. The finger escape sign is when you have the patient extend the fingers and adduct them. And due to some of the weakness in the hand from impingement, you'll notice the 5th and 4th digit start to drift. This next one here, B, is the grip and release test. So you'll have the patient make a fist, open and close quickly. If they can't do it 20 times, if they do it less than 20 times, that's considered positive. And that's in the 10-second time span there. And then C is a hyperactive pectoralis reflex. This is when you tap that tendon, and a positive finding is when the shoulder adducts and internally rotates the arm.
Fires plate major.
Right.
Inverted radial reflex?
Yeah, D is the inverted radial reflex. That's tapping the distal brachioradialis tendon, and all the fingers will flex.
It should extend, but it flexes.
Right.
And then the last one, the Hoffman's?
The Hoffman is when you flick the tip of the distal third finger, and the first digit and second digit will flex.
Good job.
So these signs, what does each one tell you specifically? Like, is this for myelopathy or what? Like, how did you use them to diagnose this patient in particular?
He had none of these. He had nothing.
Okay.
And I found these don't help. I mean, I think if a patient has it, you can tell the patient, look, you're released, you're not inhibiting these reflexes, and more likely you need a surgery because it's affecting your spinal cord, and you're not inhibiting these reflexes.
So are these all based on myelopathy? Like,
Yeah.
Okay.
Yeah.
So based on the reading, these kind of help you localize where the lesion might be on exam before you look at imaging.
Right.
So it's kind of a mix of upper motor neuron and lower motor neuron. So a lot of the hyperreflexia and spasticity is the upper motor neurons.
So we hear a lot as reps in positive Hoffman sign.
Correct.
So you're just flicking the ring finger?
The third.
Middle finger.
The middle finger.
Yeah.
And then what's the reaction?
Some people have it and they don't have myelopathy.
You do?
Some people just have it sometimes.
Okay.
Yeah.
I mean, that's the one I've associated with just working in the hospital. It's usually the one I see.
Right.
That, we describe in your exam. So I don't know if that's the most sensitive or.
It's the easiest. I think it's the easiest and quickest one to do. That's why everybody does it.
Yeah. And the patients can't fake it,
They don't know what to
They have
do.
no idea what they're looking for. Yeah.
Okay. Go ahead.
So in this patient, what did you find?
Nothing.
Okay.
No abnormalities in
So no
exam.
hyperreflexia.
Nothing.
no
Normal
problems,
guy.
no defense.
His only thing is, his only problem was he can't go up and down steps. His legs don't work right, which is a big problem for him. And this episode of electrical fence.
Okay.
That's it. But if you work in a boiler room and you're going up down steps all day and you can't walk right, that's a big problem. So he knew he had a problem. Okay, any other?
Are these tests designed more for radicular symptoms for nerve root
compressions?
No, for spinal cord. So usually this is inhibited by your brain, and that's blocked because of the stenosis. So these reflexes come out, and it means the spinal cord is severely compressed. Okay, and I just reviewed, I feel obliged to do a literature search before these things. So I found this article, C71, you guys can read it, but it didn't help me too much in my understanding other than C71 disc herniations are usually foraminal and there's no joint ischia there. The sternal notch was at the T2, T3 disc space. It's kind of interesting. So, and guys interrupt if you want to add something, please. So Dish was the name was given by this guy in the bottom right, Resnick, in 1975. I think it's from UCLA at the time. And it was like 20 cases, diffuse idiopathic skeletal hyperostosis. Before that, most people called it for SDA, which was just spine, but he added the diagnosis with the extremities too. And the diagnosis is flowing ossification. He said 4, but some people say 3 continuous vertebra. The disc is normal. There's no fusion of the facets, and the sacroiliac joints are normal. So basically that rules out degenerative disc disease and ankylosing spondylitis. And this is like a classic, if you see this CAT scan on the right there, this is a classic flowing ossification for dish, and this is sagittal cuts. And then the question is, this is trivia, does the aortic pulsation affect the location of bone formation in disc, you think? Yes or no? Yes? Allison said yes. So seeing is believing. You can see the aorta and you can see how there's no ossification there. And just, it's very uncommon in young people, but as you get older, like say age 65, 28% of the specimens had dish. Risk factors, metabolic syndrome, diabetes, increased age, high BMI, uric acid, and metabolic syndrome, if you guys forgot, central obesity, high blood pressure, high triglycerides, HDLs, insulin resistance, basically me. And then, and then this is just a graph of age. So as men and women, the big one's men, the other one's women. You see as you get to 80, half of people have dish, which is, yeah, it's incredible. So that in my mind is, this is what I see a lot of 30-year-olds in my office. They have severe back pain. Everything's normal. And I usually tell them, you probably have dish. And it's just not on the x-ray yet. And because half of us are going to get it, as guys especially, and they have symptoms, and I think people feel better when they know what they probably have, you know. So I think it has helped me talk to patients that you do have a problem. It's not a surgical problem, but you do have a problem. It's usually not a big deal.
It's not preventable. You have to wait until it's actually developed.
No one understands how to prevent it, yeah. And just symptoms are usually just pain, stiffness. The other ones usually don't happen. And the difference between dish and ankylosing spondylitis, dish looks like a flowing candle. Ankylosing spondylitis looks like a bamboo pole. I'll show you. This is more dish. And this is an x-ray of ankylosing spondylitis. The ossification goes up and down like a bamboo pole. Here's a totally fused lumbar spine, ankylosing spondylitis. They're osteopenic, dish is usually osteodense, and the sacroiliac joints are fused. The bone scan looks like metastatic disease. Sometimes you can have these big spurs that can compress the esophagus. And on exam, you can do a Schober's test. We used to do this in residency. You have somebody bend forwards and the skin doesn't really expand because the spine doesn't expand. And I sometimes put my hands on the patient's ribs and have them take a deep breath to see if they move. Do you do anything else?
No.
I mean, it's easy to make big breath and hold and feel the ribs. It's easy to do. And just so anybody wants to know who Schober was, he was just a German physician who worked in France. And the differential diagnosis for dish, ankylosing spondylitis, reactive arthritis, psoriatic arthritis, rheumatoid arthritis, acromegaly. And I put this cartoon just to remember up and down osteophytes, ankylosing spondylitis, horizontal osteophytes, dish. It's just a way to remember it. So this is, Allison, what do you think? Are the joints fused in this patient? Like see the facets, you can see a line there. What do you think? Not really, right?
Yeah.
You can see the joints. So this patient's probably dish, but in this person, see how all the joints are fused there? The ribs are fused to the spine, the facets are fused. So I feel it helps me tell patients that you probably have dish because there's no fear of the unknown. So people are always afraid. They have like this catastrophic problem in their body. Nobody can tell them what it is. Everything's normal. It drives people crazy. It's just like Jaws. I know when I watched Jaws and I hadn't seen the shark yet, I was terrified. Like, what is this thing? It ate a girl. It's tearing up a ship. What is it? And then once you see the big shark, that's okay. It's a big shark. I can deal with that. So I feel like with patients, if they understand what it is, they feel better about it. They can get their head around it. What do you have any tricks to explain things to patients, Ray?
Yeah, I mean, I think that's one of the key things is if you can tell them, a lot of patients come in with back pain and, they might have like some, an annular tear or some hyperintensity on the disc or, some facet arthropathy. And you're like,
Which is very painful.
Yeah, and it's very common. And they're like, the MRI looks relatively normal, but there's this one thing, well, I think it's due to this. And it just gives you comfort. It's like ordering an imaging study just to give people peace of mind, basically.
Yeah.
So.
Yeah, and if you can tell patients what it is, it's going to go away. It's,
Right.
Yes, it's incapacitating.
Right.
It's not a surgical problem. It's going to get better.
Right. I appreciate that.
Yeah, they appreciate it. So another problem with this disease is there's a delay in diagnosis and fractures. So if you have a fused spine, you can fracture all the way across it. If you fracture all the way across it, it's a big problem because you can have a neurological injury and it tends not to heal. And some of these people get chronic spondylolisthesis where it's kind of like a non-union. It keeps moving. It can't heal because the lever arms are so big and it looks like an infection. So here's a case of a spondylolisthesis, not infected, just a fracture that never healed. And people think it's an infection. I'll show you a case of that. And sometimes the tendons can get fused. Here's the sacrotuberous and iliolumbar ligaments are fused. And this dish is an enthesopathy where the tendon, you see the tendon goes to the bone. There's fibrocartilage. Some of it's calcified, some of it's not. It's a disease of this part of the tendon. You can see it in, I'll show you. And the other interesting thing is the ossified bone anteriorly can be really big. It can be up to 1 centimeter, 2 centimeters. The other thing I found is the periosteum is really thick sometimes, and you just go through like 5, 6 millimeters of periosteum. Like, what is going on here? I think it's disease of the periosteum. Okay, so this is, anybody want to ask any questions or comments about DISH? Okay, I'll just keep moving if that's okay. So this is just another case of DISH. You can see the,
So what about the etiology? What's the latest in the etiology of DISH? Or, is it a rheumatologic disease?
yeah, I think so, spondyloarthropathy. I mean, this is not what I do, obviously,
Right.
but I think it's sort of like a cousin of ankylosing spondylitis,
Right.
psoriatic arthritis. It's an autoimmune disease that I think some people have a predisposition to, but if half people get it as they get older, it's very, very common. So probably most of us have predisposition to it. Although I have seen a 90-year-old woman with a normal spine. I mean, the whole spine is normal, and I was shocked. I was like, how can a 90-year-old have a normal spine? And so obviously there's she hit the genetic lottery, she was a normal genetic person. But it's beyond what I know.
So I remember for residency, like the one take home, like you always learn things if you create a distinguishing, framework between two things. Like, so what's the one distinguishing thing besides the flow of the osteophytes that I always remember was like ankylosing spondylitis, SI joints are fused, DISH, SI joints are not fused.
Mm-hmm.
So that's like the one thing, you gotta.
And facets, and the facets and ribs.
Yeah.
Because you'll see it on the CAT scan.
Right.
All right, it's good. So let's got 2 more cases and we'll go back to our case. This is a case I had of a 64-year-old man with right shoulder pain, obvious DISH, diffuse ossifieds, normal disc spaces, severe right shoulder pain. You can see the framing on the right at C3, C4 is stenotic. And then sagittal cuts were not that helpful, multiple bulging discs at multiple segments. And then on the axial cut, you can see this really large right-sided C3, C4 osteophyte. So this is just a case of DISH that also had a right-sided large C3, C4 osteophyte. The other thing DISH patients get is heterotopic ossification when they have a total hip replacement. So they're very high risk for that. You can see that right hip is totally fused, which is not good.
Patients with DISH are predisposed to this?
Yes, so they all need the treatment, either radiation or I don't know, indomethacin. What's the latest now? Do you know?
Usually, from the We've seen it's usually the radiation treatment stuff.
It's quick. You get the radiation done, and you don't have to worry about it.
The
Yeah.
same day or the day after,
Yeah.
after surgery, and they get it out of the way.
Yeah, you don't have to worry about people being compliant with the meth center or whatever. And they also get bilateral symmetrical enthesopathies. You see the calcaneus, the olecranon on the right. I'm going to skip this. This is just osteophytes. I thought one of the radiologists is going to come. He likes to talk about osteophytes. I'll just skip it. Claw osteophytes. So I wanted to name my own osteophyte. What would you call that osteophyte? I want to name this because I see it all the time and I don't know how to describe it. I want to call it an island osteophyte. What do you think, Ray? What would you call it?
I call it a teardrop osteophyte. It's like a little tear kind of dripping down the little spike that's heading.
Teardrop?
Yeah.
Okay, I'll use teardrop.
Fang.
Looks like a fang?
Yeah, I like that. Or
Okay.
tooth, maybe a incisor or something.
Stalactite? Well, we got a lot of options.
Yeah.
All right, good. So this is one more case I want to just go over of ankylosing spondylitis, 66-year-old man who was in physical therapy for 4 months and his back pain just would not get better. And then the orthopedic surgeon finally sent it to me. All he had was an MRI. Diagnosis was thoracic osteomyelitis, physical therapy. I ordered the x-rays. I saw the x-rays like, this guy's got ankylosing spondylitis. And it's obvious on the x-rays. But all he had was this MRI, which looks like a spine infection.
Yeah.
So his diagnosis was spinal infection and back pain, and he kept going to infectious disease. It was like a really 4 months of this poor guy. And I got x-rays and a CAT scan, which clearly showed a fracture through and through the spine. You can see on the top and on the coronal sections. And the MRI looked very similar to an infection. You see how it's really bright in the disc spaces. And then in surgery, it was quite obvious where the sucker is. There's a crack all the way through. So I was wondering, how am I going to find where the fracture is? Because you can't. This guy was a huge guy. I was like, wait, maybe I'll just see it. And I was like, and it was clearly obvious. So it was easy. It was easy for me to know where I was. And he went for 4 months. This poor guy.
It's right there
Huh?
where the suction is.
Yeah, right where see the black line going across where the suction is. That's where his fracture was. Because it's a through and through fracture. And I just did 4 points above and below. And he had immediate pain relief. Okay, so now back to our patient, 61 years old, myelopathic leg weakness. What do you want to do, Ray? What are your thoughts?
So basically, I typically get x-rays and a CT. You have the x-rays, I probably get a CT scan, just look the bony anatomy. I'd want to know on the CT scan, are those calcified or not calcified? So, the two options would be anterior versus posterior. If there's a lot of osteophytic calcification, then I'd probably go posterior. So I'd probably get a CT scan initially.
I agree with you completely, and I'm going to tell you why I didn't get the CAT scan, but go ahead.
And then, it looks like you could do a posterior decompression. There's 3, 4, 5, 6. So you could do a C7 laminectomy and then do like something like a C6, C7 to T1, T2 fusion would be one option. Or go anteriorly and do a C6, 7, C7, T1 discect ACDF. So those would be the two, the two options basically.
Yeah, so I agree with all that. And I think if you take off 7 and you get down to T1, you should decompress everything. So my thoughts were, I was concerned about the T1 slope. It was such a high angle. I felt that he was at risk for non-union because of that. So I want to do a posterior laminectomy infusion, C6 to T1, and then take him back in 2 weeks for an anterior column. And I'm not going to decompress the spinal cord anteriorly because it'll be decompressed posteriorly. And just to ensure that he doesn't get a non-union, because I think it's really high risk because his head's tilting forwards a lot, the T1 tilt. So I think we're good. So because of that, I didn't get the CAT scan. So just the case was 3.5 hours. Did exactly what Ray said. C7 laminectomy, removed a little bit of 6, a little bit of T1, put lateral mass screws at C6, straightforward at C7 because at C7.
Lateral mass at C7 or did you pedicle?
I do straight. Well, let me show you. I forgot to talk to you about this. Let me show you C7. I forgot to show you this because it's important. C7 is always hard for me. So here's my pre-op planning. Here's C7, bottom left. So vertebral artery is like, where are you going to put the screw there? I mean, there's almost nowhere to put it. So I basically just did a 10 millimeter screw straight in. And I know I'm not going to hit the, yeah. And I think where else are you going? You can't try to get the pedicle in there. It's too dangerous. It's not worth it. So I just did like a short screw at C7. But I knew I was coming back anteriorly, so I figured I don't need fantastic fixation. My 6 screw was really good, and when the T1 screw is the strongest screw you can put in.
So how do you decide between doing T1 alone versus T1 and T2?
Well, I was going anterior, so if I go anterior, I'm fine.
I got it. Okay.
And with a plate, I'll show you. Yeah, I think the same thought. So I think an anterior approach is just really easy. So posterior approach, right iliac, I did iliac crest, lateral mass screws, C6, C7 pedicle screws. The case took me 3 hours. You can see intraop, it's very hard to get an x-ray. And here's his post-op x-rays, looks pretty good. So my question to Fabian is, do you think the spinal cord will look decompressed with a posterior approach only? Look, just imagine in your mind. You think that's gonna look great if you remove the C7 now, there'll be still some pressure there?
There's still going to be some pressure there. Or actually, it's going to be, I think it'll be substantially decompressed, but there's still going to be a little bit of anterior.
There may be some pressure there, right? Because the discs are pushing backwards. I thought the same thing. So here's the MRI. And it looks incredible. So it doesn't, I don't think it needs a second surgery, right? I was surprised how good it looks. But I still did the anterior, and you can see the axial cuts. I still did the anterior. Spinal cord looks great. I did the anterior because I feel it's high risk for non-union because of the tilt, cervical thoracic junction. It's like the base of a tower.
For stability.
Yeah, for stability, yeah. So I took him back 2 weeks later for an anterior approach. This is the anterior surgery. I didn't decompress the canal, so that makes it a lot easier. And the other thing that's difficult is at C7T1, you can see your view right over the clavicle. I always remove like it's like a trapezoidal piece. And here's the post-op x-ray. And patient went back to work at 1 month. He said he felt great. And I asked him, I was like, how's your sloppiness in your legs? He said, what are you talking about? I don't have sloppiness in my legs. I was like, wait a minute, don't you remember like you couldn't go up and down steps? He goes, oh yeah, that's right. He just totally forgot about it. Which is good, because I kind of like that in one sense, because the patient moved on with his life. He's like, I'm good, I'm back to work, boiler room, I'm playing golf. I'm not a patient anymore, I'm just a person. Here's the obliques, and I saw him 10 weeks post-op, and he's doing fantastic, really happy. So that's it. So any questions about this case, or diffuse idiopathic hyperostosis, or cervical myelopathy?
So how do you know when you were able to get down to C7Q1 anteriorly? Like, what are your
Pre-op?
Yeah, preoperative. Like, what do you look for?
I look at the clavicle, I look at the sternum. So this case, I'm pretty sure I can do it. But look, let's say, Ray, let's say worst case scenario, I take out all of T1, and you can definitely get there. And then you just put the plate on. We have posterior screws, so we don't have to worry about much motion. Should be no motion. So I can just take out all of C7, put in a corpectomy cage and a plate. And you don't have to worry about the plate with the corpectomy cage because we already have posterior screws. So that's my fallback. It's easy. It's really easy.
Take out all C7.
If you need to.
Right.
But usually I just take out off the inferior third. It's easy. I've never needed more than a 12 millimeter graft, and I just shape the graft with the allograft that looked like a trapezoid, and I stick it in. Worst case scenario, if you don't want to use a cage, just get a fibula. Just cut a fibula, shape it exactly like you want, put it in. So that's always, so I don't worry about it. I can always do that. Yeah, because the plate has a really big angle. What's your angle in your plate?
Like 30 degrees.
Yeah, it should be easy.
It should be enough.
It's 29.
It can't, we gotta be clear.
Okay.
It can be challenging. We just did one last week and we had some issues getting those down.
T1?
Yeah, it was tough to get to the angle. So we had to do a lot of bend at the bottom. And it was case very similar to this. It's a lot of ossification in the front portion of the cervical spine. Do you think you should have gone up any higher and taken care of any more of those osteophytes while you were already there?
No, I resist the temptation.
Less is more.
Yeah, I don't think I need to do anything, because he's not stenotic.
No problems with esophageal dysphagia at all?
No, this guy's a horse, no problems.
Yeah.
And the next day he was eating steak. He's
Let's see.
like, what? Like, swallowing problems? No, I'm hungry. He's like, guys don't.
Sort of guy.
Huh?
He's a mean potato sort of guy.
Yeah, he's like, well, I want to go. The only thing he's asking, when can I go back to work? Because he kept saying the guys need me. He's like one of those people, the guys need me in the boiler room. I was like, go back tomorrow. He's like, wait, I can't go back tomorrow. I was like, go whenever you want. So he doesn't, and some people, this is my opinion, but when people are focused on their job and their work and their families, they don't think about disease. They just move on. And they don't worry about problems like that, which is nice. You know, they're focused on their lives, and that's why I want
Those are
people.
the people you want to take care of.
Yeah, they do great. Yeah,
I mean, once you get better, right? And once they finally get the surgery.
yeah, patients like him don't. Yeah, they're incredible patients. What else? What other comments?
How do you typically manage these patients? Obviously, they're not surgical. What would you typically do for a patient that's 45, 50?
Normal MRI and X-ray.
Apart from that,
And we think it's early dish.
we think it's really dish.
Well, let's ask Ray. Ray, what is your cocktail?
I missed that. I was just looking. Go ahead.
So I was just asking, what's the the treatment or the conservative treatment for patients that are non-surgical that have dish when they come into your office and they're having pain.
Ray's a neurosurgeon, so just remember that he's not a primary care.
Yes, I know, but
Yeah, I mean, it's all the standard conservative treatments, usual physical therapy, anti-inflammatories, Mobic,
all right,
general altering activities, just the typical, yeah. So, Stuart, did you put a graft in, or,
I put in allograft, cortical-concellus allograft, composite. It's in the inside.
can you see it? I mean,
No, you can't really see it. You gotta believe me, it's in there. Hold on, let me show you.
6'7".
Let me show
You can see it on the other image.
Ray doesn't believe me. See right there? It only goes this deep.
Okay.
And this, see the angle here? His body is so long that it's only
I think they're only 12 millimeters deep.
yeah, they do it on purpose because they don't want the graft to the spinal canal. Yeah. What else? Any other questions or comments?
so when you put in C7 screws, like what, you can make an argument of skipping C7, going up to 5/6 and then down to T1, because, when you put in a C7 pedicle screw, it kind of overlaps with that T1 screw sometimes.
Yeah. Big C7 pedicle, totally normal C7 T1 disc space, vertebral artery is not in the way. Especially if I have to do a frame anatomy or I have to do a laminectomy, I usually just remove the top of the most superior portion of T1 and C7 so I can, C7 so I can palpate it. So then it's easy. Yeah, you have the Penfield 4 right on the medial wall pedicle and you know your angle and it's easy. But if it's hard, I don't do it because I feel it's not worth the risk.
Like you do it more in these shorter segments versus a C3 to T1 or C2 to T2, but
That's kind of a different, it's a different case. So you have a very long lever arm. Yeah, people have studied this actually, and it's not clear what the right answer is. Do you include C7T1? But I usually, if I don't have to, I don't. But I don't take risks with the vertebral artery, and if it's small, I think I don't want my ego to get in the way that I should do this because I'm the best surgeon in the world. You have to, you gotta weigh your risks. So having said all that, it's rare that I do a C7 pedicle screw.
So there's, if you look at the numbers, usually the vertebral artery enters at C6. I don't know the exact percentage, but I'd say there's less than, and I'm just throwing out a number, maybe 10 or 15% actually go into the C7 foramina. So the majority of them enter at C6. So, I'll always look at the MRI preoperatively, whether I'm doing an ACDAP or poster. I always look at that vertebral artery just to make sure that it is entering C6. But if you transition from C6 to C7, you start to see it flow away from the, anterior spine. So, that's what I'll look for. So I'll tend to put in a C7 pedicle screw, but Sometimes you'll see, anyway, so, yeah.
But you make sure that it's,
And I put in
It's easy.
short screws, so it's, so if you look, so for example, if you look at that lateral view right there, you can see, and I think we talked about Fabian, we did a posterior cervical
Yes.
recently.
Yes.
So if you have a screw that doesn't traverse the posterior aspect of that vertebral body, there's no way you can hit the vertebral artery, because the vertebral artery is going to be sitting anterior to the posterior part of that vertebral body. So those screws in no way can touch the screws in C5 and C6, that's where 3, 4, 5, and C6 and C7 are never going to touch the vertebral artery because it's posterior to that posterior longitudinal line, basically.
that's a nice pearl.
Yeah. So
Something
if you see
simple.
it, yeah. So a lot of guys will put in very short. Another way to do it is to put in a very short C7 medical screw. So if you put in like a 10 millimeter or 12 millimeter in C7, it's very unlikely you'll hit the vertebral artery because it can't reach that far in. So, I mean, you probably put in longer screws. Yeah, I guess those are 10, but yeah. Anyway.
That's what I basically did.
Right.
Very similar.
Yeah. So when do you use the Bendini?
Bendini.
I don't think we've used the Bendini.
You got to use the Bendini.
Yeah, we haven't, I don't think we've done a really good posterior cervical.
Yeah.
They're so.
I'm scared of the Bendini.
It's great. It's great.
No, it's great.
I'll put in a plug for you guys. So, yeah.
The Bendini is awesome. I love the
We used
Bendini.
it on that case that we did. Didn't we?
I don't recall mentioning the Bendini.
One a month
I think
ago.
recently, a month ago, we used Bendini, yeah.
The best Bendini story I have is I was looking at all the screws and I was like, wow, this is going to be a weird curve. Weird. I did the Bendini and then Derek goes, it's straight. I was like, what do you mean it's straight? The Bendini says it's straight.
Didn't have to do
I was
anything
like,
with the rock.
you're kidding.
Been there a bunch of times.
He's like, the Bendini says, give me that rod. Yeah. Yeah.
Just the words of.
Well, thank you, Bendini. Yeah.
You're right, he's been there a bunch of
I was
times.
ready.
Wait a second, why did we put
Straight?
Cut an 80 to a
Yeah.
7.
Are you serious? Straight? Yeah. Sure enough, it fits.
Right.
That's a,
about to like bend it or this.
Well, we had it all, what, Sheila's ready to go.
that was the best Bendini.
All you gotta do is cut an 80 rod to a 70 screw. That's it.
Yeah. I was like, this is not going to work. Let's see. I was like, oh, wow.
But it's amazing, like all the like lightning bolts and zigzags, and you're like, well, this isn't gonna work, and you put it in. I think you had a surgeon that used to work with in St. Agnes. It's like, this isn't gonna work, you know, and it's just like, boom.
Any other questions or comments? So I can shut off the mic. Questions or comments?
Joe Burrow's gonna go against this street.
Who?
Joe Burrows,
Who's that?
Cincinnati. He's gonna,
Joe Burrows?
yeah, we're playing Cincinnati.
He's going to die, poor guy. He's going to get crushed.
He is, isn't he?
Yeah, I hope he doesn't get hurt because he's a great athlete. But the Ravens are going to crush him.
He did last year, right?
Huh? Yeah.